The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. We're very excited this month to be able to talk to Josh Bonkowsky. We talked to Josh about 5 years ago about other stuff. And, it's interesting for me to be at the stage of life where I've been able to see someone like Josh go from a physician scientist of great promise to a physician scientist of great stature. And in addition to that, he's just a truly interesting and decent human being. So a really nice person to be able to talk to. Welcome back to the podcast, Josh.
Paul, it's so nice to be back. It's good to see you here and excited to talk.
Yeah. Now, before we start, we should mention your disclosures.
Yes, my disclosures are that I am involved in writing content for Up to Date. And then I have done consultant work with the company Ionis, as well as am involved in clinical trials with Ionis.
Terrific. So part of the occasion for us talking today is one of your other disclosures. You've just written a book. It came out in April, right?
That's right. This book is called Dancing Eyes, Dancing Feet. I started about 10 years ago, so I'm relieved that it's finally done and coming out.
Yeah. What made you want to write a book?
I realized about 10 or 15 years ago that I was coming home or meeting with friends, going on runs with people and telling them stories from the hospital and from the work in science. And it seemed interesting to me, and they at least pretended to be interested in what I was telling them. And so I thought, well, the stuff that's happening is really different than people have thought about pediatrics, and outside of our kind of ivory tower or outside of these especially hospitals in pediatrics, the world doesn't realize how much stuff has changed. And I wanted to bring some of that changes and knowledge and excitement and hope really to a broader audience.
Well, in reading the book, it strikes me as part memoir, part meditation, part reflection, as you say, on the way things have changed. But one of the things I really enjoyed about it is the reflective part is that I think as you do that, there's great appreciation for where we've come from and, some of the things that we need to retain from where we've come from. You talk about some of your mentors, and we'll reflect on that a little bit more, but people like Fran Fiu and Joel Thompson and Jim Bale, people who are from Utah will know these names. These are legendary names. And looking at the sort of personal qualities that you appreciated in them, I think is really quite nice how you reflect on those qualities in an era where we know more about the science of medicine than we did 50 years ago, that those humanistic qualities can't get lost.
Yeah, I think that I've been extremely fortunate in my training, not only in pediatric neurology with the people they mentioned, Fran or Jim, but that the mentors in general pediatrics, people like Bruce Herman or Jeff Shunk or Ed Clark, people set role models. And it's a little bit scary now to find myself in the point of my career where I'm supposed to be a role model for other people and wondering, am I living up to those same standards? Am I setting the example for what I would hope the next generation kind of carries forward as physicians and scientists? And so it's a little bit daunting to be in that point of a career.
And I suspect they all felt the same way.
I hope so.
Yeah. The other thing that I think is so nice about the book is that the problems that you talk about, both the practice of medicine problems and the disease processes, are all personalized with case histories and that sort of thing. And what comes across, I think, is a great appreciation both for the burden that people carry with diseases, but also of the clinician's journey through that. And you don't shy away, a few times you wish you had done things differently. And I think that's what we learn from. I think the ability to be able to be reflective about the things we do right, the things we do wrong, helps to make us better clinicians.
Yeah, I think especially as a specialist in a children's hospital, the specialist I feel can often kind of hide or duck a little bit behind our expertise, and we're not sometimes at the same front line that a general practitioner is or someone in the emergency department. But the medicine is so complex, it's good to let people know that there's things we do really well, and there's times when things don't go well. And the not going well is not a good thing, but on the other hand, owning that it happens and that we can kind of try and fix those problems, I think can make the whole system work better. Be like, oh yeah, that wasn't perfect, but we can do a better job and we don't need to be extraordinarily upset about it. We just need to work harder on it.
And I think almost all of us find that the way we do things is colored both by the things we've done right and the things we've done wrong in the past. And being able to learn from that and appreciate that and being open to that is what gives us the promise of being better at what we do.
For sure. I think if I had a nickel for every mistake I made, I'd be so well off that it's good to think along those lines and good to be humble about it because, of course, we're really happy when we do good things and be proud of those things, but not be afraid to say when we don't do as good a job.
Yeah, and the other part of it that I think you humanize very nicely is that, you have a life in the lab and you have a life in clinical medicine as well. And when something doesn't go well in the lab, it's disappointing. But when something doesn't go well in your clinical life, there are people involved. And I think your book very kindly reflects the notion that you appreciate that.
Yeah, I think that's true also, like it's true as the provider, but it's also true for the parents because they certainly didn't ask, to have some rare genetic disease in the family and they're just thrown into this foreign world where they're trying to make decisions that they have no context for and getting information from social media or from the web and some provider for a disease they hadn't heard of until a week ago. And so having compassion for those families and their journey is also important.
Well, I wanted to start this week by talking about a couple of diagnoses that I've paired together to ask you to talk about. And these are both observational diagnoses. We're going to talk a lot more about specialized diagnosis and treatment going forward. But I wanted to talk about, first of all, something that you have had a big part in changing the name of. And that's when a concerning event happens with a young infant, and we're trying to sort out what the meaning of that concerning event is. Now, I'm old enough that when I was training, they often referred to these as near SIDS events, which, is a horrible thing to be able to say to a parent that you just caught your child in the process of dying. Thanks for bringing them in. And had gone from there to apparent life-threatening events, ALTEs. And your observations have changed the way that we've seen these so that they're now BRUEs, brief, resolved, unexplained events, right? Am I getting that right?
That's right. And I think I came in at the tail end of the SIDS era or near SIDS era, and then was firmly in my training during the ALTE era, and then hopefully helped push the field forward into the BRUE era.
I want to pair that briefly as we go along. We want to talk about both of these, what they are and what the importance of these are. But the other thing being complex functional neurologic disorder. Am I right in saying that's what has sometimes been called conversion disorder in the past?
Yeah, FND or functional neurologic disorder has been through probably 10 or 12 different name changes, each one slightly better than last. I think the most concerning was, and I'm not even sure I can remember the acronym, but like non-epileptiform seizures starting with the letter P, and that acronym didn't work. But now I think most people have settled on functional neurologic disorders or FNDs. And that field or that kind of area of understanding in pediatrics has really improved as well in the past 15 years.
And in both of these problems, the origin of this is the observation, usually of a family, that something abnormal is happening. In the case of Brueys, that something has happened to an infant. Why don't we start there? So describe what a Bruey is.
So a BRUE or a brief resolved unexplained event is defined as an episode happening to an infant less than a year of age. It has to be less than a minute. It has to resolve. There can't be some other explanation. So if a child has a known disorder and it's just another type of episode of the same type, then it's not a BRUE and it has to be kind of a discrete episode. And those often consist of spells where the child might change color or appear to stop breathing or stiffen, have an episode that might look like a seizure to a parent. And then it resolves, and the parent, of course, is just kind of shocked and scared. And often ends up calling 911 and coming into the hospital, where the hospital then sees a totally well-appearing child and has to decide, what are the next steps? What do we tell the parents? What workup or testing do we need to do?
And as in the past, this is a diagnosis of exclusion. The difference is how much exclusion is required. Am I right?
That's right. So historically, the concern had been in the field that these episodes, when they were first called near SIDS and then when they were called ALTEs, was that this was a harbinger of disaster, that the episode indicated a serious underlying health problem that required hospital admission, lots of testing. And through a series of work, both here at Primary and Children's Hospital, also work around the country, it's become clear that these kids who had a BRUE or an ALTE are in fact fine and go on to do fine, except in a minority of cases. And so I think that the science of understanding what happened to kids long term helped us then inform what we did need to do or did not need to do in the hospital setting.
So a lot of the decision making happens from a careful history and physical exam.
That's right. I think the key aspects of BRUE are making sure there's not a abnormality on physical exam, and that the history that the parents provides doesn't point in a totally different direction. I think those two things alone help exclude most serious health conditions. I think normal vitals, of course, is also critical. If the child's hypoxic or has some other issue, that would also exclude them from being a BRUE. But the problem in the field of BRUEs and ALTEs and near SIDS have been that everything was being lumped together, both kids who had normal vital signs and kids who didn't have normal vital signs, and they just confused the recommendations. Now that we know that if you have abnormal vital signs or abnormal exam, you fall into a different category, we can kind of focus on the more kind of pure BRUE type child to make recommendations.
And the whole targeted evaluation at that point, that now you have something that you're looking at as opposed to something that was worrisome but is not worrisome, that has completely resolved whatever it is that happened, and that after careful evaluation, that then limited evaluation makes sense.
That's right. And so at this point, if you have a well-appearing child with no concerning kind of quote unquote high risk features on the exam or history, they fall into this kind of low risk category, BRUE, and really hospital admission is not necessary, more testing is not necessary, and it's mostly kind of a follow-up both with the family and with their home provider. And it's clear that kind of low risk BRUE category is truly low risk. In the long run, infants do fine, and the risk is very low for anything more serious happening.
And what's the current recommendation for how much evaluation, how much observation this child needs?
So the low risk of BRUE, other than the kind of the initial evaluation, either in the pediatrician's or care provider's office or in the emergency department, doesn't require more than kind of a standard physical exam and history taking, including a social history. I'll just say that is one thing that's important to realize, that BRUE sometimes helps the provider realize that there's stressors at the home or things that would raise the stakes for child abuse to be considered in the differential. So that's the one kind of asterisk to the whole discussion that's important for the BRUEs, is that child abuse continues to be the one thing that is uncommon, but continues to be kind of a risk of consideration in the evaluation of BRUE.
And in some ways, it sounds like you could probably make the argument that the primary care provider may be in a great position to be able to do this evaluation because they know the family and may have a level of comfort with the family that enables them to have searching conversations.
Yeah, I think that's a good point. The primary care provider, the pediatrician knows the family, and so has a context that the emergency department or the hospital doesn't have. I think that's really valuable. On the other hand, that it could put them in a little bit of a pickle if they feel like they need to do more work
Sure.
and say that, oh, I think, having an out to say, oh, this is enough where maybe you should go to the hospital because it provides a level of kind of distance to allow more workup to happen if there's concerns about child abuse, for example.
Sure, sure. But also, given that at least some part of a family is usually going to be involved with that child over the long haul, then I think you're right. Sometimes I think difficult things happen better in a different setting. At the same time, I think the implied relationship that says, when I see you next week, when I see you in a month, we'll keep having this conversation.
That's a good point. That's something that's changed a little bit in the hospitals that, I mean, as you know, the hospitals have moved a lot to kind of a hospitalist system in the inpatient side, and the hospitalists then don't see the patient and the family when they go home. So it used to be staffed, used
Right.
to torture general pediatricians to come see their patients in the hospital, but then it also meant that when they got discharged, they went and saw their pediatrician like a couple of weeks later. And so that continuity has been lost a little bit in our current management.
Let's talk a little bit about functional neurologic disorder. Describe what goes into that diagnosis.
So that's a pretty common thing we see in both our outpatient clinic settings in pediatric neurology as well as in the inpatient side. I'd say about 10% of our outpatient volume is FND, and then probably every week in the hospital we see, 2 to 4 consults that are FND, functional neurologic disorder. So functional neurologic disorder consists of a child exhibiting some sort of neurologic symptoms. Sometimes it's something like seizures or weakness or pain on one part of the body. But then on history and exam, and sometimes on some limited testing, there's nothing specific found that indicates a single discrete part of the nervous system not working that would indicate that, in fact, that it's seizures or that it's a weakness caused by nerve or brain injury. And oftentimes the exam and history, in fact, can be fairly convincing, even without any testing at all, that it is a FND, because there are certain types of symptoms that are classic with FND as opposed to being a problem with the brain or a problem with the nerves.
And I would have to say that even if I suspect that functional neurologic disorder, I would be much better served by having this patient see a neurologist to help me to establish diagnosis. Would you agree?
I agree. And I think that's something that we as neurologists don't realize as well as we should, because the pediatrician may be like, yeah, this is clearly FND, but the gravitas of, or just seeing this person who's been advertised as the expert neurologist provides the family a level of comfort and belief that things are being taken seriously and that the appropriate workup is being done. Because then when we move to the treatment of FND, it's actually quite a long path and kind of dissatisfying. And so making sure the family feels comfortable to go down that treatment path is important.
Right. Are we missing something? Yeah.
That is exactly the concern of parents. Yeah.
Yeah. And what's the usual treatment path? How
So the
does this
treatment
evolve?
path, yeah. So the treatment path, so it's basically 3 parts. The 3 parts are one, treating the symptoms that they have with interventions to improve functionality. So, for example, if they have weakness and can't walk, then working with physical therapy and occupational therapy to work on that functional aspect of their weakness. The second part is that they should work with a behavioral health specialist. Sometimes that means a medicine, sometimes not, because it's clear that from lots of data that if you don't have that behavioral health component, that the pathway to getting better is longer. And I talk to families that on MRI imaging, we can see that there are changes in the brain. These changes are on research type images, so it's not something we can obtain clinically, but the way the brain is functioning in people with FND is different than how people without FND are functioning, and we need to fix that. And sometimes that means behavioral health interventions and medicines. And then the final part is biofeedback, and families often give me a kind of expression on their face, and I'm like, yes, biofeedback sounds hokey, but it totally works. The biofeedback is basically trying to set your brain's internal thermostat. So if you think that, for example, if a child is experiencing pain, it means the brain is taking a normal signal from your arm or from your leg and instead turning that into a pain signal. And with biofeedback, you're trying to retrain the brain to turn that thermostat to taking that normal sensation and not interpreting it as pain. So biofeedback works. It's kind of weird, but those are the 3 pieces that it takes to get better. And that improvement is, it's like taking I hope in 10 years we'll have a more focused treatment. But these 3 big pieces, they're kind of clunky They take time. They're not super like, you just feel like you're kind of spinning your wheels sometimes with stuff, but we know they work. We wish it was better and faster, but it's what we have right now to get people better.
Again, one of the advantages of one of my patients, so I may see a few of these in my career. You guys see them all the time. One of the advantages, too, is what we sometimes think of as the one-stop shopping concept, that you have seen this before and this is what works, and we can help you get plugged in, and then we can send you back to your provider, and they can help you navigate most of this from there.
Yeah, 100%. When I sit down with a family, either in clinic or at the hospital bedside, I mean, I think I do play on my gray hairs. I do play that card a little bit. I say, I've been doing this for a while. I've seen lots of kids. I see lots of kids in clinic with this same disorder. We've ruled out the other scary things. We know it's not something else. We know the pathway to get better. And the key thing is to work with the family that we are not blowing them off and that we have a pathway for improvement that they can trust to work with us on.
So I wanted to transition to just one last element of what we're talking about today, and that's that both of these diagnoses are instances where you have to have difficult communications with families. Challenges being that if prognosis is good, they're still terrified. And if the prognosis is guarded, that you want to be supportive, but not give them incorrect information. How do you navigate that? Because you do that all the time.
Over time, I've definitely improved with difficult conversations with families, and there are some people who come into their careers better equipped than others to have those conversations. And I think I'm kind of medium. I've learned a lot as I've matured in the conversations that I have. When families are thrown into these situations, whether it's with a BRUE or with FND or with some bad genetic condition, the family and the child didn't ask to be in the situation. So we as providers have to have compassion that this is just as hard and scary for them as it is maybe annoying or time consuming for us. And so I think the key thing I've tried to do is it probably sounds a little pat, but to be more humble. I'm pretty certain I'm right most of the time, but to tell the family I'm probably right. I think I know what we need to do here, but if I'm wrong, I'll still be following up with you, still be working with you, and we can pivot or change the plan if the pathway is not heading in the right direction. So I think knowing that you're not throwing them out there and that you're working with them, I think is the biggest aspect that makes them feel some level of comfort in what you're doing.
And it occurs to me that, because I think one of the most difficult jobs that we have sometimes is communicating uncertainty without either making them feel despair or panic. And it occurs to me that what we were talking about at the first of the episode, that for one thing, humanizing the experience, seeing people and trying to work your way into understanding just a little bit what they're going through, but also offering to be with them along the path counts for a lot.
Yeah, and I can think very clearly. There's a set of conditions that I take care of called ALD or adrenoleukodystrophy. And so if you have this disease and you live in the 20 states closest to us, you probably end up coming to see me. And so I see a fair number of these patients. And so I have a pretty good sense of what I'm doing, but I recall every time I see a new patient, the one boy who I thought had ALD had all the symptoms of it. And then a couple months later, I realized like, oh no, I've made a mistake. They have multiple sclerosis and I've totally whiffed this one. And so the family that was very kind about it because we had been working together through the whole process. And so I think they realized the good intentions and hard work on our team's part and my part, and that we were there within the whole time. And so even when we got to the point where I realized like, oh, I've been down the wrong pathway here for the diagnosis, I was able to kind of quickly get them to the right person. And they were very kind about the kind of hard work that we've been through to make a wrong diagnosis, essentially.
The difference between a wrong diagnosis and a right diagnosis sometimes is a matter of time, and sometimes it's seconds, but sometimes it's a lot longer than that. And I think that it does imply that we all deserve to have a certain amount of humility that says, keep thinking.
Yeah, and in this case, it was good learning experience for me as the quote unquote expert in this disease to realize, man, and I had contacted people around the country, other experts, and just we were all incorrect, but not leaving the family out there to try and do it on their own, I think was the key feature that made things turn out okay in the end.
Just to close on a note, a quote that you cite in your book from the legendary Joel Thompson, that it's not our job to take away hope. And I think that there's a lot to be said for that because we often do give people very bad news, but it's never our job to take away hope. And I think it's always our job to show empathy and kindness.
Yeah, I think even with the hard diagnoses, it's not the path or the journey that they wouldn't want to be on, but there's still rewarding times and fun times on a path that's not where you want to be going. So I think even with a child with a terminal diagnosis, there will be fun picnics and fun movie nights and things you can do together. And so making sure they enjoy those moments is important.
Yeah. Well, on that note, thanks, Josh. If people wanted to buy your book, Dancing Eyes, Dancing Feet, I ordered mine online. Available at all fine bookstores?
Yes, so it's available at the King's English here in Salt Lake City if you're in
Legendary bookstore.
Utah. Or I think for most people, it's probably most easily available online through Amazon, or there's an ebook version on Biblio.
Yeah. Well, thanks for writing it. Thanks for being willing to talk about it. And thanks for being willing to educate us more about some of these things. We'll talk to you again next week about advances in diagnosis. Thanks for talking to us, Josh.
Thank you, Paul.
And to our listeners, please send your questions to questions@vcurb.com. We'll deal with those in a couple of weeks. Thanks for listening, and tell your friends about us. See you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.